Hello, my name is Robert Hamilton, and I'm excited today to launch the next installment of our webinar series. We have a wonderful panel today that'll be discussing the latest advancements in clinical research in right-to-left shunt and PFO detection. And we're welcomed today by a number of three individuals very excited to talk about this interesting topic around cryptogenic stroke. The first will be Dr. John Volpi, who is the director of the Eddie Skurlock Center at Houston Methodist. Then we'll have Dr. Rubin, who is the service chief of neurology at the Edward Hines Jr. VA Hospital outside of Chicago. And then finally, we have Dr. Ruchir Shah, who is the stroke program director at CHI Memorial in Chattanooga, Tennessee. Very excited to talk about this topic today, and we'll be starting with Dr. John Volpi.
Thank you, Robert. I'm going to share my screen, and I just want to say while we're doing that and getting that taken care of, I want to thank you and NeuroSignal for your commitment to this topic and helping to really iron out the wrinkles in a very difficult field. So do we have the right appearance there? Is it full screen?
If you can just go to presenter mode.
Okay, let's try again.
Great.
All right. You're seeing the full screen version of that?
We are.
Okay, great. Well, yeah, thank you again for having me. So, I have a mission here and really to talk about, what happens when you first see the patient, when you're approaching a patient with a stroke and they have an etiology and you're trying to kind of navigate what can be a difficult field. And really, it comes down to kind of the importance of diagnosis. The more I've been involved in this, the more pleasure I get in really this kind of Sherlock Holmes approach to what we sometimes have to do. There's so much information now we get from the ER that when it's not obvious what the cause is, we do have to kind of think about it. I think everyone is familiar with the common form of stroke etiology and classification, that being the TOAST criteria. It's not the only criteria, but it's definitely the one that has the most used criteria. And we've got that large artery atherosclerosis, which again, you'll probably know on day one, if not minute one, cardioembolism, which is what we'll be talking about, small vessel occlusion, stroke of other determined etiology. So these may be patients who have a dissection or vasculitis. And then that stroke of undetermined etiology, which we labeled a cryptogenic stroke. And just as a reminder that when you've got competing etiologies, that also considers a patient to be cryptogenic. This classification has been a useful way of studying subtypes of stroke, but it recently had a change, and you could look at the ESIS, ESIS being an embolic stroke of undetermined source. This is a Venn diagram that kind of shows cryptogenic stroke, but within that, there may be some embolic stroke, so they're of undetermined source. There's also some cardioembolic source, and they may be of undetermined specificity, what part of a cardioembolic stroke they are. For example, is it something that's just coming from the atria? If you don't necessarily have AFib, you might be kind of scratching your head. So that's kind of how it started with ESIS. The issue is this is how it's going. ESIS has become kind of a much broader Venn diagram that kind of encircles everything: athero, not athero, vasculitis, patients who have all different risk factors, inherited coagulopathies, autoimmune, all kinds of things that could potentially look like ESIS and find its way into this construct. And with this kind of concern, there was recently an editorial that said, maybe it's time to say goodbye to the ESIS construct, that it's run its course. And why is that? Well, the real outcome of the ESIS concept were ESIS trials. And the hypothesis was that if you have an embolic stroke of undetermined source, you might be able to lump those diagnoses into this construct, and then you could treat them all with a direct-acting oral anticoagulant. And by simplifying the diagnosis, as long as you know the patient doesn't have large vessel disease, then you get this one-size-fits-all medical management. So Navigate ESIS was a rivaroxaban study, Respect ESIS, the Vigatrans study, and most recently Arcadia was the apixaban study. All of them were negative. And so while we wanted there to be this embolic stroke approach with a direct acting drug. None of the direct acting drugs won the day in their prospective studies. But what we're left with is that there is not a one size fits all medical management, that diagnosis matters. So when we think beyond the vessel, we may think about imaging. Can imaging differentiate an embolic stroke versus an atherosclerotic small vessel disease? So pop quiz, this is a small subcortical infarct. Is this atherosclerosis or embolism? You'd see this on rounds, maybe on your DWI or maybe even on your CT. It certainly looks like it could be a small vessel disease, but we know that emboli can mimic small vessel disease. And both of these were patients who had known embolic sources, left ventricular thrombus in one and an AFib event in the other. So tip of the basilar kind of event on the CT scan, and just a small distal embolism on the DWI. So we know that emboli can mimic the appearance in small vessel disease. What about things that look like emboli? These are patients who had, kind of a distal cortical small infarcts. Is this atherosclerosis or an embolism? This is certainly something that we look for when we think about an embolic stroke. Well, in both of these patients, they had known atherosclerosis. They had large vessel stenosis, and this was the last place the blood got and the first place that had a stroke. And so you can also have a mimic from large vessel or atherosclerosis that can look like a small embolic infarct. So I might say that MRIs are a bit of a Rorschach test, that you may see what you want to see. You may have different interpretations based on your approach to the patient. And sometimes it feels a little bit like this, that we're with our cardiologists and we're both looking at the same imaging and we're both saying, whatever it is, I didn't do it. It's not the brain's fault. The heart doctor's saying it's not the heart's fault. And so how do we manage that dilemma going forward? So the first question, of course, is it AFib? AFib or no AFib? When the patients are in the hospital, they get a few days of monitoring, probably not enough. If they go out, they can often get a 30-day event monitor. They may have alerts, but they may not be true real-time alerts. They may use wearable technologies now. And of course, then there's the implantable, which would be the highest grade technology and lasts a couple years. But again, the alerts are delayed by a day or two. Why would we consider patients for implantable loop recorders? The Crystal AF trial. So this was looking at implantable technologies versus routine monitoring. And in the patients who had the implantable, there was about a 10% per year detection of AFib. And I'll just say that there was an observation that I like to kind of recall from this, is that the difference in the slopes of the curves of detection. Within the first 60 days, there was a fairly steep detection rate, and then it was essentially linear after about 90 days. I don't know for sure what that means, but one of the things I tell myself is that the first early phase were the AFib events that were probably linked to the stroke, versus the later detection may simply be common risk factors or even the stroke autonomic changes that are leading to AFib. So not necessarily the cause of the stroke. So we know that there's about a 10% per year detection. We know that 30-day monitors may not suffice. We may need something longer than that. And then we have this dilemma of whether late AFib was even the cause of the index stroke. So what are we to do? I think this is a case where we can go back to the table 1 for the studies that we're looking at. If we look at the baseline characteristics of the Crystal AF trial, these were patients who were over 60. They were patients who were enriched with vascular risk factors, and many of them had had previous events. Versus the patients who were in the reduced trial were 45 years of age. They had generally not having vascular risk factors, and other than having an event, they had not had atherosclerosis incidents before that. The other thing we know is just the overall incidence of AFib in the patient population below 60 is very low, less than 1%, and even lower under 50. So what is my takeaway from the Crystal AF data, as well as the REDUCE and other clinical trials and PFO closure? It's that you have to have certain considerations. I would say that in a patient over 60, you should consider placing a loop recorder, In a patient with multiple vascular risk factors, abnormal left atrium also would be patients I would consider. But in an otherwise healthy patient under 59 without typical vascular risk factors, I wouldn't consider it. And even in that borderline patient who's maybe in their late 50s, early 60s, if they have a normal echo, normal EKG, no family history, that would be a patient I would also consider deferring a loop recorder. So if we move from AFib as the embolic cause, we may move to PFO in the properly selected patient. And this is one way to analyze your patient. And many of you are using the ROPE score, and I hear about it now very frequently. So I won't review all the different details that go into the ROPE score, except to show one quick case. This is a patient who's 34 years old, smoker, has had a prior stroke, a cortical appearance, but no diabetes and no hypertension. So he gets some points, and then he gets his age. And that would lead to a ROPE score of 7. And his ROPE score of 7 means that his PFO is likely the cause. There's more than 50% likelihood that it's a PFO attributable. And the 2-year risk recurrence is about 6%. So when you look at that, and that 6%, you may think that's a 2-year risk, a 1-year risk would be 3%. That's about what we saw in the pivotal clinical trials for PFO closure, that this population was at about a 3 to 4% chance of recurrent stroke per year. So what are some pros and cons about ROPE? Well, it's helpful for guiding conversation. I often do this right in front of the patient, but it doesn't include echo parameters, and there's a strong age effect. So what else can we do? The Pascal categories are very helpful, and they're something I add on for most patient discussions. So this takes into account the ROPE score plus high-risk PFO features on echo, like a large shunt or atrial septal aneurysm. And then the patient gets in a bucket of either unlikely, possible, or probable if they have none of these present, or if they have 2 of these present. What does it mean? It means that they're relative risk reduction. So if you have a possible patient, the PFO closure is a 62% relative risk reduction, and in a probable patient, it's a 90% relative risk reduction. And so we know if about 75% relative risk reduction is what was seen in the overall studies, it was a mix of about half of each. Finally, I just want to cover a few things about PFO and aging. We may look at patients in the ROPE score and see that they're not getting enough points because of their age. What do we know about PFO and age? We know that the incidence of PFO goes down, but the actual size of PFO increases slightly. The other factor with PFO-related stroke is clot. And we know that the risk of clotting increases with age for venous thromboembolism. And if you were to put an inflection point, you put it between 45 and 55. Other things about thrombophilia are not necessarily genetic, but are acquired and associated with aging, like cancer, chronic disease, and obesity. We also know that shunt itself may increase with increased right atrial pressures, and that also increases with age. So one thing I like to say is that PFO-related strokes are both a stroke of the young and a stroke of the middle age. And if we're looking for perfectly healthy young people, we may miss many patients. So I'd like to just kind of wrap up my part by saying there's about 800,000 strokes per year in the US, and we think about 200,000 on those ESIS type strokes. Of those, 20 to 100,000 are patients with PFO. And if you're in a large center, you might be closing PFOs at a rate of 1 to 2 a week. And if you're not, you may be under detecting them. Finally, if you believe, sometimes people tell me they don't believe in PFO closure. I just say that, do you believe in treating hypertension? Do you believe in lowering LDL? Do you believe in antiplatelets? Do you believe in diabetes? All these things are listed here with their relative risk reduction. And then last, what closing a PFO's overall relative risk reduction is. So with that, I'll wrap up my part and pass it over, I think, to Dr. Rubin.
Thank you, Dr. Volpi. Dr. Rubin?
Okay. Thank you, Jay. Yeah, while we're getting my slides pulled up here, I'm unable to share at the moment. Jay, I think you have to hit the stop here. Share. Perfect. I don't know about the rest of you guys, but you have me convinced that it's important to make the diagnosis right to left shunt. And conveniently, that's what we're going to be talking about here, sort of mechanically, how do we actually make these diagnoses? So thank you to Robert and the rest of the NeuroSignal team for inviting me and my friends here to talk TCD, which we love to do. So let's talk about right to left shunt detection, where we've been and where we are now, and look forward to getting to where we're going with it. So we'll talk a little bit about transcranial Doppler and the detection of right to left shunt, and we'll talk about our recently published bubble trial. So anyone who works in a stroke ward knows that the sort of the frontline diagnosis for a number of things related to potential stroke mechanism is the transthoracic echocardiogram, to the point that let's get an echo is shorthand for this specific test, even though there are a number of types of echocardiography. When people say echo, they usually mean transthoracic echo because it's ubiquitous. We make the diagnosis of right to left shunt with agitated saline contrast. The video that's playing there, this is a 4-view apical view of the heart, and we look for bubbles coming into the right atrium and then right ventricle and see if any cross over into the left atrium or left ventricle. It's widely available. Essentially, every hospital has echocardiography. It's non-invasive. Most shunting, most right to left shunt is intracardiac through a patent foramen ovale. So it would stand to reason that looking at the heart in a non-invasive fashion would be a good way to look for something like a patent foramen ovale. But it turns out it's pretty insensitive for PFO as compared to transesophageal echocardiography. Transthoracic is only about 45% sensitive, meaning it misses it more than half the time when the PFO is actually there, that a TEE would have caught it. The transthoracic misses it. It is nice and specific, so if you find it, it's there. But as a screener test, being worse than a coin toss is not a good screen. We can do transesophageal echocardiography also with the agitated saline contrast, as we see coming into the right heart here. And we can visualize the interatrial septum very well with transesophageal echocardiography. It's considered the non-invasive gold standard for PFO diagnosis, but it's a to-do. Any of those of you who do this in practice know that it's a special room, and the people are given special medications, and it's not 24/7 available. There's more risk. It's not a surgery, but there's more risk to the patient than something that's purely non-invasive. And especially since maneuvers like Valsalva increase sensitivity of right to left shunt testing, when you're given a lot of drugs so that you can tolerate swallowing a mechanical snake, how good is that Valsalva effort? So we lose out on sensitivity there. You guys may have heard of a technique called transcranial Doppler. Essentially the principle is we're listening to arteries, and then we're injecting, again, agitated saline contrast, so air bubbles into veins, and listening as to whether or not those bubbles are going from vein to brain. So it's a nice direct, view of what we actually care about. Do the veins have access to the brains, to the brain, to the arteries? This has been done for the last 30 something years. We have standardized technique, not only with how the agitated saline contrast is put together, but the Valsalva can be metered and calibrated either by manometry or looking at characteristic cerebral arterial waveform changes. We've demonstrated that there's positioning that increases sensitivity, such that someone who's sitting up, it's better for sensitivity than someone who's lying flat. We have defined clinically meaningful results. So we just learned about the Pascal schema, and when we're talking about large shunts, we can define that not just by what it looks like on echocardiography, but how functional is that shunt? How many bubbles are coming across and making it from a peripheral vein into intracranial arteries? And we find very consistently in observational reports over the worldwide experience over the last 30 something years that transcranial Doppler is extremely sensitive for any right to left shunt. Not all right to left shunt is intracardiac or from PFO, but it does happen to it's highly concordant with transesophageal diagnosed PFO. The drawback is that it's not push button. Classically, it's a relatively difficult technique to do, which we euphemistically say it's operator dependent, but in human speak, it's hard. So I'm going to read every single word and every single line here to you now. This is the rich worldwide experience of doing transcranial Doppler bubble studies. Some of them, as compared to transthoracic, we've noted consistently that transcranial Doppler outperforms transthoracic echocardiography for the diagnosis of right to left shunt. As I got to know this as a trainee, someone comes in like, oh, okay, let's get an echo. Well, it's an embolic stroke. Oh, echo is negative. Like, but we know that it's not a great screen, so should we do more? And particularly, being the only one around who could do TCD, it's just not widely available. It's like, what am I missing here? Why, if we know that there's a good screen and it's not invasive, why does this feel lonely? So it was with great pleasure to work with Neurosignal and my friends on the webinar here today to address this personal grievance from my training through the trial that we affectionately called Bubble. This is a TLDR kind of title, but really with the introduction of the autonomous robotic technology that can drive the transcranial Doppler, hey, maybe we can actually bring this technique where it's not being done because it's too hard and there's a lack of expertise. This makes it as push button as some other diagnostics that we're used to. Now's our chance to demonstrate, to our colleagues and to the world of, hey, there's a better way to be doing this. That was the goal of Bubble. So formally, we wanted to evaluate the right to left shunt detection rate of the autonomous robot-assisted transcranial Doppler device, the NovaGuide system, and we compared that to the standard of care diagnostics, especially transthoracic echocardiography. It was a multi-center prospective single-arm consecutively enrolled diagnostic accuracy device study. We enrolled adults who were already coming into the hospital because they had some kind of clinical event that made us worried that they had an embolic stroke or TIA. So they were already going to be getting a workup for embolic stroke, including a transthoracic echo with agitated saline. And we sort of snuck in the robot-assisted transcranial Doppler within that workup. And those were the comparators. Patients could have regular TCD and transesophageal echocardiography, but that was up to the treatment team. So just to show you what the device actually looked like, the patient was either lying down or at 45 degrees, and the device is able to autonomously find a signal on each side when two transtemporal windows were to be had. It could find signals, hold on to them, and this is what allowed us to bring this device and technique to places that otherwise did not have TCD expertise. And the people who ran this device were clinical research coordinators who were healthcare professionals but did not have TCD training prior to the trial training that we gave them. So the primary endpoint of Bubble was the % detection rate of right to left shunt. And it was the robot-assisted transcranial Doppler diagnosis against the local read, the true standard of care of the transthoracic echo. And the safety endpoint was just incidence of any kind of device-related serious adverse events. As a key pre-specified secondary endpoint, we wanted to see how robot-assisted transcranial Doppler versus transthoracic did in picking up large shunts, something that we would potentially intervene upon. So we enrolled 154 patients, and 129 of them ended up evaluable in the intent to scan, which is a device trial. This sort of our intent to treat, but this is the intent to scan. Every patient, even though we had a pretty open inclusion, a set of inclusion criteria clinically, everybody had an acute stroke or TIA as their qualifying clinical event. 47% were women, and the median age was 61 years. So overall, in these 129 patients, the robotic assisted transcranial Doppler was positive in 82 of the 129, 64, almost 64% of the population. And in this same population, echo found any kind of shunt in only 20% of the population, for an absolute difference of 43.4%. And thankfully, there were no serious device-related adverse events. Of significant importance, of significant importance was the percent detection of intervenable shunts. The robot-assisted transcranial Doppler found large shunts in 35 of our patients, or 27% of the population, and the transthoracic only found it in 13 patients, or about 10%. So that was also significantly different statistically, but also just from from a basic standpoint, when you're using this test to screen, the transthoracic echo was completely negative for any kind of shunt in 18 of these 35. So it's not like there was oh, well, this one called it a grade 2 and this one called it a grade 3. It was completely negative for any kind of shunt, and it was suggestive of a small shunt in a handful. And to show an example of this, here's one of the study patients, 4-chamber apical view. We see the bubbles coming into the right side, and we don't see any bubbles coming into the left. Transcranial Doppler, we're going to see good Valsalva effort, see the waveform changes, and upon release of Valsalva, a very positive study, and a very unsubtly positive study. So this was not a rare event in our trial. Oh, let's skip for a second there. If these videos were playing, you see that this was not a rare event in the trial. Again, there were 18, or more than half of the large shunts that were detected by robot-assisted transcranial Doppler were completely negative on echo. So presumably that should give some pause to anyone who does this in practice. We pretty much go around hoping that we don't miss anything in our patients who are depending on us. That was a pretty sobering result, but not surprising given what had been reported up to this point. So overall, the robot-assisted transcranial Doppler, the NovaGuide system, was substantially more likely to diagnose right to left shunt than transthoracic echocardiography as performed in the community. The absolute difference was huge. The robot-assisted transcranial Doppler detected intervenable shunts, large shunts, at about 3 times the rate of transthoracic. And again, less charitably stated, the transthoracic missed or underestimated large right to left shunt in almost 2/3 of cases, and more than half were completely missed by the transthoracic. The device was safe, and it was technically feasible for use by folks who didn't have any TCD training before we showed up with this device. So from this, we can not only did we show prospectively what people have been saying with retrospectively for decades, but the robot-assisted transcranial Doppler appears to allow providers to achieve the known sensitivity of transcranial Doppler for right to left shunt detection without the need for the folks to do it at the bedside who are hard to come by. This is relatively push button. So for the visual learners, transcranial Doppler is the superior diagnostic for right to left shunt as compared to transthoracic echocardiography. We're glad to have just published our results. It's in this month's stroke journal, the AHA Stroke Journal. We're also featured in the podcast. And happy to talk TCD after Dr. Shah.
Great. Thank you, Dr. Rubin. Now we'll be going over to Dr. Shah to talk about his most recent results.
Okay, you guys can see my screen? Okay, thank you, Dr. Volpi and Dr. Rubin for this presentation, and thank you, NeuroSignal, for invitation. It's a very important topic, and for the vascular neurologists or stroke neurologists and many like neurologists like us, that it's important to diagnose your stroke patients, the etiology, and what's the basically the cause for the strokes, and then only you can work on the prevention. And we know the how likelihood of this, like the recurrence of the stroke, means to our stroke patients. So it's kind of this topic of discussing and diagnosis of cryptogenic stroke becomes very important. And we still haven't figured out the whole pathway of how to make it more standardized, more in a guideline, that how, when it comes to cryptogenic stroke, what workup is enough and what should be the bare minimum workup as well. But that's, I think, kudos to all the leaders in this field who are keep working on to make it more standardized. So by saying that, we just kind of want to confirm that what we saw in this bubble trial and what we know the information, how does it reflect in the real world as well? So at CHI Memorial, we have been using this TCD for a while, and I'll kind of want to show that what we have done, our work here. So as we all know, the stroke is #1 cause of adult disability, and that's why we're talking about stroke and things. But in that, like etiology, the PFO, it becomes an important factor and cause for the stroke, especially as Dr. Volpi mentioned, that it's in a young population, right? That's the average age is around 45 to 50. And if they have no other traditional risk factors, it becomes important that you go further to diagnose those patients for other etiologies, including the PFO. So why do we like, what is the difference between traditional transcranial Doppler that's been in place for many years? People do traditional TCD, and why the robotic TCD becomes more important and useful. When we started like a kind of program, we've been doing traditional TCD, but it's always challenging to find a tech with the good skill to do this traditional TCD. And it's also always becomes difficult as well if patient does not cooperate well, or if you just lose the signal while they are doing the Valsalva. And it's always hard to keep your probe at one place when you are doing the bubble study. So it's basically, you require dedicated tech to do this. It's difficult to perform sometimes, and you have variable quality based on TCD tech at that time. So how does the robotic TCD comes into place? That is, it's basically, as Dr. Rubin showed you the video, that automates the TCD data acquisition without the need of trained TCD technician. It's a bilateral and fully you see the signal on both sides at the same time. And then it's a long-term monitoring. You can monitor for a few minutes or hour, depending on your requirement as well. So we have been using at CHI Memorial in Chattanooga, Tennessee, we've been using this robotic TCD, even not just for the research, but as a commercial in day-to-day practice for almost 3 years now. And this is where, when we were also part of the bubble trial, and when we are doing the bubble trial, we also want to show to the world that how does it reflect into the real world. And Dr. Rubin mentioned this TTE was negative and TCD was positive. In those patients, it's not just a subtle positive, very significant. We see that very often in day-to-day practice with our commercial TCD use as well. So why TCD is like more sensitive than transthoracic echocardiogram? It's basically you have both MCS being isolated simultaneously. It stays on the vessel for the entirety of the time. It bubbles moving all in one direction directly at the probe, and you have tightly concentrated MCA, much smaller than the size of atrium compared to echocardiogram. And then you also TCD machine can count the bubble, which allow us to assess the size of the PFO. So TCD also, it can see through the temporal bone in 93% of cases. And sometimes the TTE, you might not have good quality based on the body habitus and other anatomical factors. And you can confirm with the good Valsalva, like you have with the TCD, you can see the drop in peak flow velocity. So you have more calibrated Valsalva that you can monitor on the screen that, okay, what was the Valsalva effort when you did the TCD? So as Dr. Rubin mentioned, that this was just published this month, and Dr. Devlin and me were part of the clinical trials, and we are very fortunate to be part of the clinical trial with Dr. Rubin and Dr. Alexandro's leadership. So now we did our own QI project here at Memorial Hospital that we compare transcranial Doppler for PFO detection versus standard of care bubble study using transthoracic echo. So over the period of 3 years, we have around 193 patients, and 147 patients who received both TCD and TTE bubble study. And out of those 147, 11 patients, around 7.4%, had no window using the TCD. And this, we just presented this data at World Stroke Congress in Toronto, and our APP nurse practitioner Jennifer Patterson presented that result, and was very well received there as well. So what was the result of the trial? So it shows a similar finding, close to similar finding than what we show in the bubble trial, that it shows significantly higher PFO, around 60% bubble detection, PFO detection compared to around 37% with TTE. And of the positive PFO, around 42% were large, Spencer grade 3 or more, compared to TTE as well. I'll show you in the next screen, but it's again like we have so far, and this is like we have to update this. It was like 4 months before, but we have close to 10 PFOs out of those, and 2 of those were completely negative on TTE. So it just shows you how it makes your makes a difference in the patient care and secondary stroke prevention. And we have integrated like TCD into our cryptogenic stroke management of detection of PFO for the last kind of 3 years at least. So it does show a significant increase in detection of PFO, and that kind of confirm that what we show in the bubble clinical trial, that it's in the real world, is a similar finding, and having that robotic TCD in part of the cryptogenic stroke workflow and ESA's workflow it becomes very important for a day-to-day practice. So as Dr. Devlin, our neurology chair, would say, and if anybody knows him, I consider him as a guru in stroke finance, that if you work with him, you have to know the finances, stroke finances as well. So because to get all this technology, all this thing, you have to convince your CFO as well that why is it important, but they only look at on a financial side that how it becomes important for the hospital. So when we review those PFO closure cases, that average total charges were around 52,000, and we have direct cost of around 12,400, and then average contribution margin per patient, which was like around 6,400. So that's very significant contribution margin when if you miss that PFO, and ultimately main outcome is in the patient care, that you are preventing the secondary stroke. Of course, that's on the clinical side, but it also makes sense to understand the finances, that how is it important by closing the PFO, how your hospital is also not just losing money, but it's actually more beneficial. we also presented this at SVIN in November 2023 as a poster. This finding. So yeah, it just kind of validated what Dr. Rubin and Volpi says, that having kind of standardized workflow for the cryptogenic stroke and having the robotic TCD as a part of that workflow it's very important. But at the same time, it's also important to understand, and that's where your cardiology and neurology team comes together, that not every cryptogenic stroke and PFO is a cause for the stroke. So there are much more, and that's a different topic to discuss, that who are the right patient that you close the PFO. Not every PFO and cryptogenic stroke you want to close as well. At Memorial, we kind of try to utilize there's a workflow and how we follow through for cryptogenic stroke patients. And as you can see, the TCD is in the middle of this workflow, that any patient who has possible cryptogenic stroke or ESA stroke, and if you feel like the TT is negative or equivocal, then they get the TCD right away. That has been educated, and that's been part of our workflow across all our neurology staff. So we do it on a daily basis, these things, and it does make a difference in the outcome. And that's all on my end. And thank you so much once again.
Perfect. Thank you, Dr. Shah. Now we have a few questions here. I'd like to start, open up the roundtable, with the team on one. Appreciate the summary of the complex topics, given that everything from diagnosis and understanding the TOS criteria all the way through trying to understand the finances of a PFO closure. So there's a lot to unpack. The first area I wanted to talk a little bit about, and I'll start with Dr. Volpi, is really with Pascal coming out a few years ago, obviously using echo as a screen. What role do you think adding transcranial Doppler into that Pascal criteria would impact those results? Is that worth something looking at?
Yeah, I mean, I think that from a practical standpoint, it's just another way of detecting large shunt. I think that it is, even though those were echo criteria, that there's not any reason I wouldn't consider a patient with a large shunt on TCD to be different from a large shunt on echo. So I would, in other words, to answer your question, I would put that patient who has a large shunt would be at least a present on one of their criteria on Pascal. And then if their rope score was either present or absent, it would put them in either the probable or possible. Either way, they would be patients who, in the Pascal classification, would benefit from PFO closure. You look at the whole patient, whether it's a score or classification, not everything is just directed by these scoring systems, but it is helpful when you're, this is hard for us. I mean, when the patients are coming to us, I like showing them the numbers, I like showing them what I'm doing, and I like talking them through it. And then we kind of just say, where are we at with this? What do you think?
No, I think it's a great point to try to aggregate that information and use the information that's available. As you start to think about really any test, beyond what we're looking at now, but just really any medical test at all, looking at the inputs into that, Dr. Rubin, as you start to think about transcranial Doppler and the factors, you mentioned it during your presentation. Are there certain factors that you believe are more important that we need more information on from a protocol perspective, whether that be IV location, Valsalva, whatever that might be, bacterial static saline?
Right. So there are technical components that have been well established that we included in our own methodology because people sort of figured this out phenomenologically and then published their experience over the years. Positioning matters, Valsalva matters. The rest has been kind of speculative to this point. That's what's forthcoming as a secondary analysis of our trial is what elements of the technique mattered in the bubble trial specifically, because the people would do things and then look back on their experience, but there haven't been any sort of rigorous clinical trials with bubble studies to this point. And so we have a unique opportunity to say, hey, of these technical features, which actually made a difference? And not to let the cat out of the bag too much, but in general, position matters, Valsalva matters even more than position, and IV location did not appear to matter. That we had the exact same diagnosis rate, whether someone had because in real life we can say, oh yeah, right antecubital vein, that's where I want it. And in the 2000 JAWS guidelines, that's what they say. There's no citation to say why they say right antecubital vein. It's not crazy to want that, and I see why it was there, but it's just not feasible in every single patient. So for our patients who have, a right pinky toe IV, that we just work with what we have in, the real world intent to scan population, IV location did not matter.
Interesting. As you start to think about, workflow and getting into the next topic, which is very complex, which Dr. Shah really showed in his last slide, which is how has the recent few years, or if it has not impacted, the role of transcranial Doppler within the overall workflow? I know, Dr. Shah, you showed it on your slides. I know the European guidelines also have a different perspective. It'd be interesting to hear from each individual, starting with Dr. Shah, on how he sees workflow and the diagnosis of right to left shunt overall. And more importantly, what data moving forward would be valuable from a standpoint of understanding or segmenting these patients to a better degree. So Dr. Shah.
I think I'll just add like the one point from Dr. Rubin's remark before I answer this question, that and I think it was a part of our protocol as well, but that we realize it happened very often that if patient has used definitely contrast injection for echocardiogram, and if you do the TCD in a short succession after that, so you can see the false positive. So in that workflow, it's important that you have some time, 12-24 hour difference after the echocardiogram to do the TCD, to not have any false positive result on that. So back to your question, I think after the European guideline, it's very heavily kind of talk about importance of TCD in the overall workflow for the cryptogenic stroke. Then the SKY guideline came out, that Society of Cardiovascular, specifically around this topic, that what PFO should be closed, and they even got to the point that the size doesn't matter. If you feel like they kind of took out the equation of size, that if you feel like it's a PFO and a kind of related stroke, then it's important to close. So it's even become more important, of course, as finding a large size shunt. But after those guidelines and those data, that finding a right to left shunt, it becomes very important itself. And having this technology in the middle of that workflow and have a standard workflow for the cryptogenic stroke for the hospital, it becomes important. We are doing a lot of studies and a lot of clinical research right now around what's the standard workflow and standard protocol for the cryptogenic overall when the patient comes to the hospital, and kind of working with other team members. And we are working on the Divert QI project right now to just kind of collecting those data and how we can fit in and make a standard workflow that we can duplicate across all the hospitals, regardless of their stroke designation. I think that becomes important to have more from kind of leaders in industry, that what kind of standardized workflow and data, and we can come to the consensus that this is what should be the bare minimum when the patient comes for the stroke, what's the bare minimum you need to do.
Right. Going to Dr. Volpi, I think maybe twisting the question or adding to the question a little bit, from a stroke research perspective, what do you think is out there, whether it's ESIS understanding AFib or PFO closure or right to left shunt detection, that is unanswered for you as a clinician, that either data is going to be coming out soon, or you would like to see more data around overall kind of cryptogenic stroke or ESIS stroke management?
That's a good question. I think, let me go back for 1 second because I want to answer about the workflow issue. I think most of us would say that there have been a number of series and a number of studies that have shown that echo doesn't add that much to a stroke workup. And, I tell that to our team. I feel like I'm beating my head against the wall, and the message back from them is, well, what's the harm? Well, the harm is this: if you end up setting up a protocol that says your TTE with bubble is going to be done in everyone under 60, and it's negative, there's a certain kind of closed-mindedness that comes. You don't have a PFO, and that kind of becomes an endpoint for a person's workup. So, what I would say is that it's really do think about whether a patient needs the routine echocardiography with a stroke workup, and if they do have a negative, that's not predictive. If they have a positive, that's predictive. But if it's a negative, it's not predictive. And to circle back with that patient, often as an outpatient, and do that TCD as your confirmatory one way or the other. To answer the question about ESIS, I think that we know that there's a high detection rate here with TCD. The main question is TEE. How does it compare in patients who have a positive and had a negative? What are we at with TE? And although most of them are PFOs, some of them aren't. So there's other right to left shunts. And I would be curious to know more about how we can work those up, and what is this novel tool, TCD, telling us about right to left shunts that we didn't even know was out there as a risk for other strokes.
I think that's great. There's a number of questions which we'll get to shortly from the participants, around that topic. But we'll just finish briefly with Dr. Rubin on any thoughts on workflow or remaining data from your perspective that you see out there.
So I want to echo everything Dr. Shah and Dr. Volpi now just said. That I've, even in different centers, I've had the same experience, and I even alluded to those were Mugatu's crazy pills there of like, what am I missing? Like, I think I'm reading and studying the same things everybody else, and why do we say, well, echo negative, and shrug our shoulders? So it's a cultural change. That's sort of the subtext of everything we're saying, is that there needs to be a cultural change in the typical stroke workup, and in particular, since a lot of stroke care is not done by vascular neurologists, we need to make a stroke workup accessible to the broad spectrum of folks who are providing care for patients who've experienced a stroke or are at risk for stroke. Part of that is making the diagnostics available. That the push buttonness of a technique, as much as we can get it there, that it can still be accurate but relatively easy to use, is going to be important to to make sure that that people can actually use these things that are of use to patients. Echo is kind of there. It's in every hospital, and that's why there's a culture of we do echo, and I heard it's kind of a heart thing anyway. So it's either I'm looking at the heart, of if it's there, I'm going to see it, but no, that's actually not the case. And I'll also echo with the issues of workflow, these secondary analyses of the technical components, I are important. And as you know, we're kind of funneling the abstract toward practice-oriented societies and publications, because when we're in practice, because there's a lot to do, we're always looking for ways to be efficient. We want to do things that are of use to patients, and we don't want to spend time or patients' time, our time, or any risk doing things to patients that are not of great use to them. It appears going through the Valsalva effort and the positioning of the patient is not one of those things that we can cut out from the workflow, because in our trial, and it again, as it was very consistent with what's been published for decades, is that those features are important, and that corners that we cannot cut.
Makes sense. Well, I want to make sure we get to the some of the questions here. Thank you for the discussion. To Dr. Volpi, we'll start. Using TCD has to. How do you distinguish right to left shunt from PFO versus pulmonary AVM or other intrapulmonary shunts?
Yeah, I mean, I'm a big believer in the gold standard. If our patients have, tests that don't agree, I work with our congenital heart team, and we say, do we really think this could be a PFO, even though the tests don't agree? Yeah, let's go take them to the cath lab and see. And the main thing we've learned over the years is really preparing the patient, because they can be a little crestfallen if it's not there. So to tell them that it's important to look for this. And it just so happens that our congenital heart team are also capable of, looking for pulmonary AVMs that are large. They may not detect every little one, so that they'll try to get that. And then if we simply find nothing, I don't know. I think I'm alone in wondering whether PFOs are variable structures, whether they're there one day and not the next. The congenital heart people tell me that's not possible, but I do. It does kind of keep me up at night.
Question I'll give to Dr. Shah. How do you confirm good Valsalva with a TTE?
I think that's like one of the limitation of TTE, right? That you cannot kind of really well see. Of course, you can see the return of inferior vena cava, that you have like a return of that blood flow that you can see in the TTE, but then you don't have any objective feature on the TTE that you can really confirm the good Valsalva.
Yeah, that makes sense. A question from Dr. Demchuk I'll give to Dr. Rubin. What is the optimal positioning for the Nova Guide to perform bubble studies? If two upright is challenging with the system, what are your thoughts in practice on the use of the system from a positioning standpoint?
Good question. Good to hear from you, Dr. Demchuk. According to Bubble, 45 degrees upright, which was sort of the compromise, because in practice we do 90 or just sitting up straight if we can. And with the particular system at the time, there were some concerns with just the weight on the shoulders. If I recall the study design meetings correctly, that it didn't seem feasible to get people at 90 degrees. So we tried 45. And I was actually relatively skeptical. I'll share that I didn't know that that we either go all the way to 90 or, let's not test the positioning aspect, but I was wrong with that. Now looking back at it again, 45 made a difference. It didn't make as big a difference as Valsalva in terms of shunt grading, but it did make a difference, and then I would be willing to speculate that 90 degrees would make an even greater difference. I would have to defer to Dr. Hamilton and his team as to whether or not we can start to sit people up with the robo.
Yeah, the indication is up to 45 degrees, so that's why that decision was made within the study. A question here: can you tell us the robotic transcranial Doppler device? Does it have a brand, and what brand is it? I'll give that to Dr. Rubin.
Yeah, it turns out it was the Nova Guide device made by our hosts at Neurosignal.
So, last question, which might be a little complex. I'd like to, we can throw it out to the panel here as we end. We're getting close to the top of the hour. Is a lot of times significant shunts are defined as Spencer grade 3 and above, and during Valsalva, as you talked about, Dr. Rubin, being an important aspect of getting that higher grade. What are the general thoughts on resting grades of 1 and 2? Is this unexplored? Is it something that, to your point, Dr. Rubin, about the importance of Valsalva, but how do you see a resting grade 1 or 2 in your workup? Maybe if that patient is unable to do a quality Valsalva for a variety of different reasons, but I'll start with you and then pass it to the rest of the panel.
Yeah, so in my practice, and the published experience, including ours, backs this up. A resting grade of 1 or 2 makes me very suspicious for what's going to happen when we sit the patient up if they were flat, or see what they do with Valsalva. There's a lot of stroke neurology that is Valsalva related. When we're finding out what happened to the person, there's a lot of bearing down that happens as just a part of normal life that we don't pay attention to until an acute neurovascular episode happens. So it's not, we're not, simulating something strange when we're asking someone to perform Valsalva maneuver. Almost always when someone has a grade 1 or 2 shunt, and then we have them do Valsalva, it's at least a grade or so higher. And that's at least often enough that I would absolutely not stop at, oh, well, there's a small shunt at rest. I'm going to send them, to the cath lab for PFO closure. It's like, let's see how functional is this shunt before considering, hey, do we need to do some cardiac imaging, either invasive or otherwise, to see is this a PFO and something we'd consider closing.
Great. And I didn't scroll down. There's one more question about pulmonary AVMs. I'll throw it back to Dr. Volpi. Do you work up every non-PFO related shunt? How do you do this? What would you recommend for the instance of pulmonary AVM workup?
Yeah, I would just say that this is where you kind of have to trust your test. So if you've reached a point where you trust your test that it's not a PFO, CT angio would be a way to go. If the patient's in the cath lab, they can do injections into the pulmonary circulation, and that's kind of what we do. Closing them, addressing that, at that point I kind of leave that to the wilderness. We don't know the answer for that. That's kind of an area of uncertainty, except that I think that a study like Bubble is really going to be looked back up as a turning point in our understanding that there's more than cardiac shunts. There's extra cardiac shunts that we need to take seriously too.
Yeah, well, I know everyone's time is precious, so really appreciate everyone's time today. Dr. Shah, Dr. Rubin, and Dr. Volpi for walking us through this complex topic. And thank you again.
Thank you so much.
Thank you. Have a good day, everybody.